patients that we were getting. So again, we did a pilot study with the rheumatologist where we looked at could we use standard points, similar points all the time, could we use standard outcomes measurements and do that in a clinical trial. And for the first pilot feasibility study of 19 patients, it really made a difference. We could do that, we found, and that reduced their pain, their stiffness, improved their functioning. And that was both on subjective and objective measures. So then we said, that's nice, let's now see if we can do this in a randomized trial where we took patients who had moderate to severe osteoarthritis, and we wanted to see, was this due to just that they got better the first time from the natural history of the disease, or was this due to the acupuncture? So then one group would just continue on with their anti-inflammatories, the other group would have anti-inflammatory medications plus acupuncture. And again, we found, this was a study of 57 patients, that the group that had acupuncture added to it, they improved as far as their functioning, their stiffness, and their pain scores on standard measures. So now we look at the third part of that, which is to look at a placebo-controlled trial. And this is what we're proposing now to the NIH to do. And now the numbers become more like 500 patients in the study, which is really what you need to do with all these studies eventually to really make a difference and to know at the end of the day, is it working or not? So we are proposing that as the next step for these studies. The other side of the clinical trials has to do with mind-body therapies, not to do with acupuncture, although what we have done is in two areas, one in fibromyalgia and the other one in chronic back pain. We developed a sort of a package program where we taught people Qigong, we taught them mindfulness meditation, and then we taught them about cognitive behavioral therapies, that their thoughts and their emotions really influence their pain, and that there are ways, positive behaviors that they can learn to influence this. We compared this to standard care. And in both cases, in the back pain study, that was a larger study of about 100 patients, it worked significantly better than standard care. The fibromyalgia patients, which is a really difficult group of patients to do anything, get any results. We have no really conventional treatments that help these patients. We have found, at least in the pilot study of 28 patients, that it's made a huge difference for the 4-month follow-up of these patients and improve their mood, improve their pain, and improve their functioning. If that was a drug, people would be going out to buy stock in that company straight away. So we now hope to take this to a larger study. So that's giving you just an overall idea of what we're doing in clinical trials. And in basic science, we have a number of basic science studies to do with acupuncture. We have one in a rat model where we created arthritis in these poor rats, and then we looked to see if acupuncture can reduce the pain and the inflammation in this model. And what we found that it has, and we've been able to demonstrate it right down to the molecular level. We're just getting these results in, and I think this is going to be very important work. We have other areas to do with healing and with Ayurvedic medicine in basic science, but it just gives you a flavor of what's going on in the program. And we chose pain, as I said before, because it's such a multi-dimensional problem that's so difficult to treat with just a conventional approach focused on the disease. And in this area, that's many times what patients come to acupuncture for, and that is to get relief of their pain. And there is about 100 scientific papers to show the mechanism of action for acupuncture analgesia, to show that something is happening there, but taking that leap from documenting what happens in rats in the lab and what actually happens to patients in their clinical conditions of chronic pain is a big leap to take. So we wanted to look at what was the evidence for acupuncture in clinical studies for chronic pain, and to assess it with the sort of tools that we now have in evidence-based medicine, systematic reviews, and what we now know about acupuncture research, and to see what do we see here. So that's what I'd like to take you through now is a little review it's a systematic review of acupuncture for chronic pain that we conducted. This was information that I presented at that November consensus conference at the National Institutes of Health. And it's also one that we've just submitted to JAMA for their November issue, which is to be devoted completely to complementary medicine, which is really a first for them. It just shows you again of that interest in the overall field. This is the authors who are involved with this. Jeanette Izzo is one of our investigators. She was over at Hopkins. She joined us about a year ago. Methodologist, as is Betsy Singh. Bishik Lau is an acupuncturist as well as a physiologist. Alex Haddad is a pain specialist, and he is the director of the Cochrane collaboration in McMaster. And then I also want to acknowledge Stephen Birch for the work that he put into this as well, which was involved with looking at the adequacy of acupuncture treatments, which was one of the very important things that we came out of this review. I'm just going to sit there and just look both ways at the same time. Basically, our aims were we wanted to see and identify the high-quality studies that exist in the area of acupuncture for chronic pain, and we wanted to look at the methodological quality and to see, does that influence the results or the outcomes. We divided it up into 3 control groups. Actually, for the one that we just submitted, we put another control group, which was the waiting list. But inert placebos, sham controls, and active controls. And when you look at this, it's obvious that the comparison group of inert controls, such as using sham TENS or sugar pills, answers the question, is acupuncture more effective than an inert placebo? So in that case, if the studies are of high quality and the results can be trusted, a non-significant finding means that acupuncture is no better than placebo. On the other hand, when acupuncture is compared to standard medical therapy, the active control group, in high-quality studies, here a non-significant result means a very different thing. It means that acupuncture has performed as well as standard care. And then the third area of sham, we chose to break it out into a separate area because there's really unresolved questions about whether it's really an inert placebo or a form of active treatment. We also wanted to look at, identify areas of methodological improvements and for identify topics for future research, as well as look at predictors of outcomes of the treatment effects. Okay. I'm going to spend about 10 minutes or so describing the methods that we used, because understanding these methods is going to really help you to understand the results that we came to. And the first part of it was the inclusion and the exclusion criteria that we used for this systematic review. Okay. For a study to be included in the review, we wanted it to be randomized. We wanted them to have pain greater than 3 months, use acupuncture, not surface electrodes. They had to use valid pain measures. They had to have a between groups analysis, and we took the studies just in the English language. That was partly due to financial considerations, as far as having interpreters, and also just not having access to that. That's something that, we need help with. That's part of what the Cochrane collaboration talks about, but to have other studies, just looking at the packet that you have, I see that we omitted one study because it was not in English language, and so that's an important piece to bring into that, almost deserves another systematic review to add on non-English studies. We selected only randomized trials for this study because it's considered to be the gold standard in scientific research. this was,
you do it from here.
Thanks. The Cochrane collaboration that I was talking about before, their sole purpose is conducting systematic reviews and maintaining these high-quality reviews. And it's something that I can give you the website, but you can really look into that depending on your area and your field of interest to have access to the information there. It's you know, they show you a very good way to use this information, and it's one, they involve consumers into this. It's very relevant. It's one of the best groups that I've seen in science to date. But they provide guidelines how to minimize bias in systematic reviews. And the way they have done it is through, one, have a broad, comprehensive, and replicable search strategy to locate the studies. So you really want to put your net as far as possible to get these studies. And then look into areas just not in the medical journals. So in particularly ones that are from searching dissertations and competence abstracts. So you can see it's a huge job to really locate all these studies, which many times they have already done for you. In this case, we did this. It took us a long time for that. That's the gray literature that we're talking about. And then to have a way of assessing the methodological quality of the studies, not just the quality of the writing and the reporting of these studies. So there have been at least 3 published reviews on chronic pain and acupuncture, all of which were published before these international guidelines from the Cochrane collaboration. None of the previous reviews met all the guidelines that they're talking about here. Because they place such an emphasis on search strategy as a way of reducing bias, I'm going to describe our strategy briefly to you. We use the comprehensive Medline search strategy that Kay Dickerson and the Baltimore Cochrane collaboration published this year, which is something like this. This is just to give you an idea. It's actually going to be in this paper that we hope will get published soon. This is the general search strategy. So you can see it's quite comprehensive and ways to do it. And I'm going to quiz Sarah in a few minutes about if she knows the what we just put up there for the search strategy. And in addition to that, we looked at our database, this campaign database that I mentioned before, which has about 10,000 studies related to all over complementary medicine and pain. And then we also looked at the field, the Cochrane collaboration field for complementary medicine. This registry is put together by the Research Council of Complementary Medicine, Andrew Vickers in London. Again, it can be accessed by you. And then, as I mentioned, this is the search strategy to look at this gray literature. We hand-searched about 30 conference proceedings and abstracts. And then we looked at the bibliographies from other reviews, other acupuncture studies, to identify the studies that we might have missed. And when we did this, we came up with several thousand titles, which we then narrowed down to 103 acupuncture pain trials with comparison groups. And this gives you a breakdown of those 103 in the different areas, as you can see. Back pain of 13, osteoarthritis of 9, head and neck pain of 21. We completely read all those, and then to see if they fit into our criteria that we'd set up. And by that, we excluded 59 of those. For the following reasons. One was that some clearly stated they weren't randomized. Others did not specify the randomization. Now for this publication for JAMA, we actually wrote to all the authors if we weren't sure to see if they could then tell us. And we included a few more than what this review I'm going to show you has. There's not much of it. And then some had pain for less than 3 months. So we didn't include it for this particular review, which was for chronic pain. Others didn't specify, again, the duration of the pain. And then some used surface electrodes and called it acupuncture. and one used the same acupuncture treatment, experimental and controlled. So all those were excluded. And we wound up with 44, actually it was 47 when we went back and got some replies from people that we wrote to for the final one. And this is a breakdown by condition of the remaining 44 trials that were certain, were randomized, and had pain greater than 3 months. Okay. The next part sort of explains about the methodological quality. And this is sort of like putting things through a methodological landmine, is how I would look at it. In systematic reviews, quality has a very specific meaning. Quoted from David Mower here, the quality gives us an estimate of the likelihood that the results are a valid estimate of the truth. In other words, it gives us an estimate of the likelihood that the results are not biased by poor study design. These were the study. We used mainly Alex Haddad's scale. There are about 25 of these scales that exist in the literature, ways to assess papers and systematic reviews. And Haddad's scale is the only one that's been validated. And it's been validated from the area of pain, so it's quite convenient for us. We use that one, and then we've supplemented this scale with other items that can bias studies according to the literature and arrived at 2 other scales with them. So this became the checkoff list, the sort of methodological landmine that we use to evaluate every study of those 47 studies. And it's basically yes or no questions. More yeses, the higher the quality scores, with 8 or more yeses giving you a high quality study rating. I think some of those are pretty self-explanatory of what they are. The concealment of allocation, it has to do with that the person assigning the groups should not know or be able to influence which way they go. You know, that would be if somebody says, okay, we're going to have this randomized study, and he puts the master list up on the wall, and so that everybody knows. That is done, I think, sometimes. What is better is if it goes to some other group that has no knowledge and they keep it and they conceal the list, or you do concealed envelopes. That's what they're talking about there, or concealment allocation. The other one is were co-interventions measured, having to do with, with pain. It's often to do with analgesic medications. Did your acupuncture work because they were increasing their medications that we're taking, or just a way of looking at to see, did you investigate what they did about their co-interventions? The other one, sufficient power, is very important for acupuncture studies. Was there sufficient power to detect a significant difference? Was there an adequate sample size? If not, it biases the study towards non-significant results. And that, in this area, for acupuncture studies in pain, is very common. The other one is were compliance issues adequately addressed. It has to do that the person receiving the total treatment they were supposed to receive, in other words, when they went home, did they actually do the control treatment, the occlusion splints or the sham tens or that? You need to at least assess, was that looked at or not? And the last two had to do with the population. The first one, a homogeneous study population, it means including people with conditions that are similar